presenter, Dr. David Lynch from Children's Hospital of Philadelphia.
Thank you, Erin. Today we're going to be talking about new directions in Friedreich ataxia. Our goals for today: understanding Friedreich ataxia, as well as the new things that are appearing in it, not only the genetic basis, but also some of the new treatments. We'd like to be able to identify the disease manifestations and understand the role of multidisciplinary care in optimizing treatment management. We also would like to incorporate some recent advances in clinical studies into patient care and provide some guidance for those of you who will be new to the field. And finally, we'll talk about some additional resources and tools that you can use to aid in your care of people with Friedreich ataxia. We're starting with an overview. Then I'm going to talk a little bit about the genetic etiology of Friedreich ataxia and the mutations which give rise to it. Then we'll talk a little bit about the clinical features of Friedreich ataxia, as well as the genetic testing, which is now the mechanism we use to diagnose FA. We'll talk a little bit more about Friedreich ataxia clinical management and those things you can do for the multidisciplinary care and the multiple systemic features of FA. We'll talk a little bit about Omaveloxolone, the newly approved treatment for Friedreich ataxia, which is reaching the market as we speak. Part of that will be the so-called MOXIe studies, the clinical trials which gave rise to the evidence in favor of treatment with Omaveloxolone. And finally, we'll talk a little bit more about the other research which is ongoing in Friedreich ataxia, as well as some of the other clinical trials, as well as how to get access to these for your patients and access to more other knowledge for your patients. Okay. Friedreich ataxia is an autosomal recessive progressive hereditary disorder. It can be classed as a progressive neurodegenerative movement disorder that results in gait and limb ataxia. It's caused by mutations in the FXN gene, which colloquially goes by the name of the frataxin gene, which logically codes for the frataxin protein. Friedreich ataxia is a rare disease affecting roughly 1 in 50,000 people in the United States. It's more prevalent in individuals of European ancestry and relatively uncommon in individuals of African or Asian descent. It affects males and females equally. We estimate there are about 5,000 people in the United States, although the actual number may be a few more than that or somewhat less than that. Typical Friedreich ataxia will first present to a physician between the ages of 5 and 15. This counts for about 75% of all individuals. Other individuals present between ages 15 and 20. And then we have a separate category called late onset Friedreich ataxia, which has some subtle clinical features, differences in clinical phenotype, which develops after age 25. The age of onset is crucial in understanding how severe things will be. The earlier your age of onset, the more severe your disease will be. Typically, people are wheelchair bound roughly 10 to 20 years after their initial symptoms. Life expectancy is shortened in FA, reflecting the underlying cardiomyopathy that occurs in some individuals. Friedreich ataxia results in 96% of individuals from biallelic expanded GAA nucleotide repeats in the non-coding intron 1 of the frataxin gene. This leads to decreased expression of the protein frataxin. In this disease, the RNA is not the abnormal feature. It's the silencing of the gene by that GAA repeat. So all the business most likely occurs at the protein level. Frataxin is a mitochondrial protein, which is implicated in a variety of mitochondrial functions: regulation of the mitochondrial electron transport chain, iron homeostasis and storage, iron sulfur cluster formation. You will recall from biochemistry that iron sulfur clusters are critical prosthetic groups in the enzymes of the Krebs cycle in the electron transport chain. And frataxin also mediates some components of oxidative stress, or better said, its deficiency mediates some components of oxidative stress. In 96% of patients, Friedreich ataxia patients have 2 expanded triple repeats, 1 on each frataxin allele. In 4% of individuals, patients are compound heterozygotes for a GA expansion on one allele, and either a point mutation or a deletion on the other. Those point mutations or insertions or deletions are associated with loss of function. So those point mutations also basically knock down the frataxin protein expression. So Friedreich ataxia can be looked at as a frataxin knockdown, not a complete absence, but a frataxin knockdown. In normal frataxin alleles, there are 5 exons, and the expansion has fewer than 30 triplet repeats. Most people have only 7 repeats in their GAA expansion between exon 1 and exon 2. Longer expansions here, typically beginning about 30, but clinically the shortest ones tend to be about 60, and going up to 1,500 repeats. They decrease the expression of the protein, and the longer the repeat, the increased severity of the disease. It's important to realize that GAA repeat expansions decrease frataxin expression, but do not completely eliminate it. In people with point mutations, diagrammed here as those, for example, with L106X, a nonsense mutation, or some missense mutations, you make frataxin, but it's either unstable and doesn't fold correctly, or it is non-functional in the case of several others. What happens in Friedreich ataxia neurologically? You see degeneration of a variety of neurological systems, but there are primarily 3 that we talk about most importantly. The large fibrous sensory neurons, particularly proprioception and vibratory sensation. Cerebellar coordination is affected with degeneration of the cerebellum in particular, and the corticospinal motor system is affected, leading to eventual weakness as well as spasticity. This, of course, gives rise to a series of neurological abnormalities. Progressive gait and limb ataxia, mainly reflecting degeneration of the cerebellum and its efferent pathways. Babinski signs, which are found early, representing the corticospinal tract degeneration. Loss of balance and associated loss of vibration. Impaired proprioception, which we believe to occur very early, usually before we ever meet people, and be relatively static over the course of the disease. So it's not really a component which is leading to progression, it's degenerationism. And finally, dysmetria, difficulty with coordination of the hands and using your hands. There's some other abnormalities in the neurological features. Hearing loss, which is a unique type of hearing loss where people are still able to hear, but they cannot discriminate where sounds are coming from in a crowded room. Thus, they will hear primary tones abnormally, but their functional hearing will be quite impaired. Loss of deep tendon reflexes, again, usually present when we first meet people, reflecting loss of proprioception. Dysarthria, but not aphasia, so misarticulation of speech, but no difficulties in language itself. Oculomotor abnormalities, as you might see with cerebellar disease, but they are quite subtle in FA. You see very little nystagmus. It's usually limited to saccadic macro oscillations and square wave jerks with fixation instability. Much more subtle things than you see in autosomal dominant ataxias. Vision loss, usually reflecting progressive optic neuropathy. This is one of the most feared complications of FA and can happen in 10 to 20% of people, particularly those who present at a young age, less than 10. And finally, dysphagia, difficulty swallowing. I would say overall, surprisingly, dysphagia is not as big a clinical complaint as one would expect it to be. These all reflect the neuroanatomic abnormalities seen in FA as diagrammed there. Moving on to the next slide, the non-neurologic features, which are in some ways more concerning, particularly for mortality. Cardiac dysfunction. The primary cardiac dysfunction is a cardiomyopathy, which leads to thickening of the heart early, but later fibrosis of the heart with loss of systolic function and lowered ejection fraction. This is the most common cause of death in people in FA. And when people have cardiomyopathy, about 50% of individuals, they die in their 20s or 30s in most cases. The second aspect of the cardiomyopathy beyond the heart failure from systolic dysfunction is arrhythmias. Usually the arrhythmias of Friedreich ataxia are atrial in origin until late. They are a nuisance, but they can be controlled by ablation or rate control, beta blockers and others associated methods. Atrial fibrillation is probably the most common arrhythmia in FA. There are also orthopedic issues. Scoliosis, which occurs in roughly 60% of patients, but requires surgical correction in a lesser amount, perhaps 20%. Those 20% are typically the people who present early in the first decade of life. There's also a loss of bone mineral density in FA, and people with FA do really have thin bones. This may be a part of their overall small stature, but this can precede the difficulties in ambulation. So it is important to know about and to potentially treat. Other aspects of FA outside the nervous system include diabetes, with roughly 10 to 20% of people having frank diabetes and a much larger number having impaired insulin resistance. Diabetes in FA can be both type 1, from insulin lack from failure of beta cells to develop, or type 2 from increased insulin resistance. You see increased urinary frequency and urgency, rarely incontinence. Usually the urinary urgency is relatively well controlled with medications. You also see a slight change in height and BMI in people with FA. Rarely is it so severe that children are diagnosed with failure to thrive or demand independent workups. And finally, perhaps underappreciated is the presence of sleep disorders in FA, particularly sleep apnea, which can be up to 20% of people with FA and can be a quite serious disorder in FA and have a major effect on day-to-day life. How do you identify Friedreich ataxia? Clinically, it's apparent by people presenting at the right time between age 5 and 15 with decreased reflexes, ataxia, usually an MRI scan, which is normal. However, that's not how we diagnose it with certainty in the modern era. Genetic testing is the way we confirm FA in the real world, and it is required for really having the diagnosis. The test to send, available at a variety of labs around the United States, is GAA repeat expansion testing, not DNA sequencing for mutations in frataxin. GAA repeat expansion looks for that expanded allele, which is found in 96% of patients with FA, I should say, which is 96% of abnormal alleles. And virtually everyone except a single person in the world has at least one expanded GAA repeat. If you find only one expanded GAA repeat, then you can look to find the second one using DNA sequencing. It will find the 4% of abnormal alleles. So do not do sequencing first, or you have negative results in 96% of people. I will note sequencing will pick up essentially all of those remaining 4%. Genetic testing is available at many laboratories. Not all of them provide the exact repeat length. Age of onset is the best predictor of phenotype, but knowing the GAA repeat length exactly is sometimes helpful in differentiating some of the features of FA from coincidental diseases. So I would say GAA repeat sizing is helpful if you can get it, but that's not always available in the modern world. But remember, and this is important because I've seen people who have gotten the sequencing first, get the expansion testing first. If you have a patient with FA in your office, what can you do? Well, until March 1st of this year, the therapeutic options were limited. Rehabilitation was the mainstay, physical therapy, occupational therapy, as well as speech therapy later in the disease. Also, an important aspect is the multidisciplinary care seeing specialists, cardiologists to manage the symptoms as they come along, though there is nothing to necessarily prevent the progression of cardiac disease. Neurologists to monitor symptoms and monitor for neuropathic pain and spasticity. Orthopedic surgeons, particularly during the time up to age 16 or 18 when children are still growing and they may need intervention on their scoliosis. To some degree, neuro-ophthalmology or ophthalmology, so that one corrects all the visual issues that are correctable outside of the optic neuropathy of FA. Occasionally, a urologist, if a person's urinary frequency is particularly intractable to standard anticholinergic medicines. And finally, sleep physicians in those cases where people have bad sleep disorders, which reinforce the fatigue of the disease. So you're monitoring their neurological features, their musculoskeletal features, their cardiac features with testing for EKGs and echoes every year, MRI if it's available, endocrine monitoring for diabetes, looking at hemoglobin A1Cs, testing people's vision to be sure that no other causes are coming up, and finally, auditory assessments to assess the issues which might be appearing in hearing. So now, on March 1st, everything changed. We now have an FDA-approved treatment called Omaveloxolone for Friedreich Ataxia in individuals 16 and older. This was based on 2 separate studies that we'll go through in more detail. First, the study overall was called MOXIe. This was part 2. Part 1 was a dose-finding study, which took 2 years to find the optimum dose and was a critical part of things. But in part 2, it was a double-blind, multi-site, placebo-controlled trial which demonstrated benefit. The second part, which the FDA was appropriately quite insisted on, was an analysis of the extension data when everyone continued on Omaveloxolone after that, to be sure that individuals, the benefit remained, as well as comparison to natural history data to show that this might be useful in a more general population. The approval is for individuals 16 and older. That mainly reflects because those are the individuals who were involved in the original study, and there's officially no safety data for individuals under age 16. I think it's logical to predict that some of those things will be, some studies in that age group will appear in the future. How does Omaveloxolone work? It's a little unclear. It has multiple actions. Its main activity, though, is it's a small molecule that activates the transcription factor NRF2. NRF2 is a transcription factor that protects all our cells from oxidative stress damage by regulating the expression of so-called antioxidant element-containing genes, those enzymes which we turn on to keep our cells from being damaged by free radicals. In Friedreich Ataxia, for some reason which we do not understand, NRF2 signaling is paradoxically depressed, and mitochondrial functions are downregulated, and we don't make enough of those antioxidant response element genes that they ought to be making in FA. This is all downstream from the deficiency of frataxin protein, which is governing the disease. But I will note NRF2 itself does not increase frataxin levels. It is acting downstream from the initial loss of frataxin. So the objective of the study, particularly the part 2 study, was to assess the safety and efficacy of Omaveloxolone in Friedreich Ataxia patients 16 to 40 in a rigorous manner. The design, it was double-blind, placebo-controlled, randomized, total number of individuals of 103 in sites in the United States, Australia, and Europe. Participants were between 16 and 40 years of age. They had to have genetically confirmed Friedreich ataxia. And in this study, they did allow individuals who carried a point mutation, so that 4% with slightly atypical disease. The key things people had to be is their MFAR score, the score which is a quantified neurological exam, which grades the severity of the ataxia phenotype, had to be between 20 and 80. 20 is a person very near presentation. 80 is a person very late stage, and I will mention that no one was higher than about 57 within the study. They also had to be able to complete maximal exercise testing, that is, be able to ride a recumbent bike against no resistance for 3 minutes at a cadence of about 50 revolutions per minute. That was used because exercise testing, trying to look at the skeletal muscle effects of frataxin deficiency, was a secondary outcome. One exclusion criteria, you couldn't have significant heart disease. So as we talk about this, you can't make any conclusion about the effect of Omaveloxolone on the heart. From a basic science point of view, OMAV ought to be helpful for the heart, but there is no data to reinforce that or negate that. The primary endpoint was the change in that MFAR scale, a quantified neurologic exam scale, compared with placebo at 48 weeks, basically 1 year, along with safety assessments, including vital signs, electrocardiograms, and adverse events, along with physical exams. As you see on this slide, looking here in gray, the placebo arm. This is the active drug arm. Down is improvement on the MFAR, so it's a net lower score over time. What you see in the placebo arm is for the first 3 months, you see a mild placebo response, and then you see people worsen over time. Interestingly, the slope of this line here is almost identical to that seen in natural history studies. So brief placebo response, and then progression at the expected rate. In contrast with Omaveloxolone for short, you see the response at 3 months, and then it persists. And it actually will persist longer than these 48 weeks, I'll show in the subsequent slide. So that at the end of this time, the total difference between the two groups is about 2.5 mFARS units. So you say, well, what's 2.5 mFARS units? The most important thing to know is that a person in this cohort would have been expected to change around 1.5 mFARS units per year. And I think you can see that as you look at what the natural history of progression is here. I have see that these 3/4 of a year is about 0.96 units. So somewhere between 1.3 to 1.5 units per year is the expected progression. So the difference at the end of this is equivalent to 1.5 to 2 years of progression. That's something that patients would tell you is clinically meaningful. Also think not so much about the 2-point difference here, but about the area of difference between the curve, which really tells you how much benefit patients have. It's time dependent, and I will note through all the different components of this mFARS neurological exam, all groups, all subsections benefited, and I would note also all subgroups within the study showed benefit. So whether you presented earlier or later, every subgroup showed benefit. Adverse event rates were basically pretty low. There were no minimally different between the Omav and placebo groups. It was basically well tolerated, very mild adverse events. Few people with headache, nausea, symptomatology, some fatigue, and occasional abdominal pain. That does lead to an increase in transaminases without any liver injury. This is thought to be a reactivation of the liver, not a toxic event. If you follow these through, people go up to in typically 1.5 to 2 times normal, and then they return to normal. It's time dependent and occurs several months after the onset and abates on its own. If one stops the drug, it abates faster. And some individuals went off and then were re-challenged without any future issues. Then there's a second part of the analysis, the so-called delayed start analysis of the extension study. So here what you're doing, you've shown in that first single year that individuals who go on MOXIe, on Omav, do better, about 1.5 to 2 years better. The question is that maintained? And what you're looking for in a delayed start is you're looking to see if people who start in the extension study start active drug, do they ever catch up to the people who started right at the beginning? If they do catch up, that argues that it's a symptomatic benefit. It doesn't change the fact it's a benefit, but it argues it's a symptomatic benefit. So the primary endpoint being judged about 1.5 years down the road is so-called non-inferiority. Are the difference between people from the original placebo group and the Omav group maintained at 72 weeks? And is the change in the Omav and placebo groups similar over time once you start the extension analysis? This is the wonderfully complex diagram of a delayed start study, which is one of the more detailed mechanisms of analysis and one of the more confusing ones. This here at the beginning is all the primary part of part 2. People go off MOXIe transiently, and then you want to see if this difference here is maintained over time as you look out here. And you look at this difference here, as you follow them along, you find that out here it is maintained and actually even grows a little bit, though that's not statistically significant. So the delayed start analysis is positive because your difference here is maintained here. If you started on placebo, you never catch up once you go on to Omav. So that is consistent with a endurance of the beneficial effect, what sometimes is called disease-modifying effect, although I hate that terminology. There is some noise in the middle here. I will note that this point here had a relatively lower number of people participating because that was right at the beginning of COVID, showing how COVID did influence some of the clinical trials we were doing. So this is a second component showing the benefit of MOXIe. You can do one more thing. My good friends in the Friedreich Ataxia Research Alliance have sponsored a natural history study in Friedreich Ataxia, which I'm actually the PI of. It began in 2002, so we now have accrued data of 20 years on individuals. You can take those individuals and pull out a matched set and compare them to people in the clinical trial. Now, this so-called propensity matching, which can calculate a goodness of fit and how well you have fit the data based on age at onset, sex, and baseline exam score. You can show that you can create an excellent match. And when you do that, going through 3 years of follow-up beyond the double-blind study, so you're all the way out to 4 years on OMAV, it still slowed the disease in years 1 through 4 by 55% compared to natural history data. So this is another way to analyze extension data, which again shows the benefit of Omaveloxolone. Based on all these things, 3 things together, that's what brought the FDA to approve the drug for people with FA 16 and older. Now, this isn't the only thing which is being examined in Friedreich ataxia, and that's why identification is still important, and we still have work to do. Omaveloxolone is a good drug, probably a very good drug, but it is not a cure. As this is the so-called Friedreich ataxia treatment pipeline given to us with by the Friedreich Ataxia Research Alliance for use here. Skyclarys is the brand name of Omaveloxolone, but I'll tend to obviously use the generic. There are lots of different things that we're looking at in Friedreich ataxia to try and find more treatments to add on top of OMAV. Improving mitochondrial function, modulation of downstream events, stabilizing the frataxin which is there, increasing the expression of frataxin by turning the gene which is turned off back on, and finally putting in new frataxin, gene therapy, or editing the gene to cut out the GA repeat. You see as you go to the right here that diagrams where things are in clinical trials. You see Skyclarys having crossed the finish line, but you see other drugs, the David in these 3 studies that will be read out soon. Some drugs in phase 2 studies, and then others going through phase 1 and all the way back to still in development. Thus, there are lots of things still going on. So if you know people with Friedreich ataxia who like to participate in studies, please let us know, and we'd be happy to try and bring them to the sites. So if you've met some new people with Friedreich ataxia, and I suspect now that we have a treatment, you will, people will come out of the woodwork, people who were lost to follow-up because they didn't know, they noted that there was no clinical trial, you may need to find some resources. There are a variety of around. Just published online and in print through Orphanet is the Clinical Management Guidelines of Friedreich ataxia, a collaborative effort across many of the expert in disease where simple situations and management of non-FA problems, as well as FA problems, are diagrammed out, selected drugs, when to panic, when not to panic. That's always a useful thing to know. In addition, you should I will refer you to the research centers of the Friedreich Ataxia Network Alliance. Soon we'll call it something else. We'll call it the Global Chemical Consortium because we're merging with the European group. This is sponsored by the Friedreich Ataxia Research Alliance, where we run our natural history study, but the patients get the privilege of seeing experts in disease who have seen more than just a few patients with FA. And finally, a lot of your patients will be interested in getting access to OMAV. There's an online site called the REACH Start Form that you can go to, get the Start Form, which actually is a prescription to help them start getting their OMAV. I will note if anyone has questions about prescribing OMAV, they're welcome to email me at any time. So it's truly a new era in FA at this point. And I think we have a lot of excitement, and it's hopefully we'll carry this excitement through to find some more treatments in the upcoming years. And with that, I'd like to thank you all for your attention.